Welcome to Issues, a show that explores issues affecting Wilmington and you, the people who live, work, and spend time here in our city. I'm your host, John Rago, and on today's program, we'll be discussing the heroin epidemic that is having a devastating effect on individuals, families, and communities here in Delaware and throughout the nation. Our guests today are Marie Allen, who authored the book Dope Help. She also directs a Newcastle County educational program called Heroin Alert. Sergeant Andrea Janvier with the Wilmington Police Department, who has over 13 years of experience in combating heroin use and trafficking. James Harrison, the Director of Operations and Communications at Brandywine Counseling Services, and Rita Landgraf, Secretary of Health and Social Services for the state of Delaware. Thanks to all of you for being with us today. You know, I consider myself a informed, educated individual, and for the last several months, my focus in terms of if you were to ask me about drugs, I'd be focusing on Colorado and Washington legalizing marijuana. And maybe because I grew up in the 60s, there's some special connection to my early youth, if you will. And then all of a sudden, you know, it's I guess if I'm an informed individual, the issue is not marijuana legalization, but heroin. And then I start learning about what's happening here in Delaware and around the nation. James, help me understand and help our viewers understand what is this heroin epidemic?
Well, John, I think you have to think about increased demand. Certainly, the purity levels of heroin are extremely higher than they were in years past. And then the whole notion of prescription drug monitoring has made it more attractive to individuals addicted to opiates. And so street level heroin has become the drug of choice.
Okay, so I can't get the pills, so I go for the heroin.
Yes.
And it's available, it's potent, it's cheap.
Right.
I would absolutely agree. I would say, in my experience, over the years, heroin nowadays can go from $5 to $7 a bag, where it used to be $10, $12 to $15 a bag. You can pay anywhere upwards of $15 to $80 for pills on the street, which become much more intolerable to take or to get. Heroin's just the easy option.
Well, if you've got prices like that floating around, that means you've got a quantity of the supply is there, and so that means the drug dealers, the business quote business people, they know what they're doing and they know to flood the area.
They make it profitable for themselves in many ways. In one example, they sell bundles of heroin, which typically bundles are from 11 to 13 bags. You can buy a bundle of heroin in the city anywhere, depending on your status as a buyer with that dealer, from $40, $50, $60 to $70. That's 13 bags of heroin.
What are we doing or not doing as far as it being so plentiful here?
Well, John, I think we also need to take in consideration the fentanyl-laced heroin as well, because we've seen record numbers of overdoses. It is not in the best interest of drug dealers for their people to die.
Can I interject on that?
Yes.
Again, I've been a police officer for 18 years, and 15 of those years have been in the drug unit, 13 as an investigator. And a lot of times we're the first ones there on the scene of an overdose. And, you know, I've witnessed people being brought back in the hospital, and they want to go back out and chase that high again. They want the near-death experience.
So the addiction's that strong. I understand. I know you wanted to take us in an area, and I appreciate that because I see the announcements coming out of the Secretary's office.
Right, the fentanyl. We had 11 deaths
recently.
Just this, and it's something that we continue to monitor. You know, the overdose death and we're not tracking necessarily heroin, although we're seeing heroin deaths as well. But it's averaging about 15 deaths per month since we started tracking this back in November. But it's interesting when you talk about the heroin epidemic, and we're actually seeing that, but it's really an addiction epidemic. And, you know, and what recently we just saw that Robin Williams, you know, suspected of a suicide, and some of his challenges dealing with depression. We also know that about 40% of individuals who are impacted by addiction have an underlying, or what we call a co-occurring disorder as well. And so the need to also address that. Sometimes people use substance in order to medicate another issue that is occurring with them.
Yeah. Maria, let me turn to you for just a moment and really bring it home for us as far as the story of your daughter, Erin. Tell us a little bit about the book, Dope, Help, and Erin's life.
Well, Erin started, the book actually was something Erin wanted to do, but unfortunately, she passed away before we got to do the book. So I continued and did it myself. But she started young, about 15, with alcohol and marijuana, and progressed until she was about 19. She started with heroin. And like Rita said, she was self-medicating because she was bipolar. And in the beginning, when we found out she was bipolar, when she was diagnosed, we did try to put her on got medication. She was seeing doctors, but she wasn't taking the medicine. Now, you can't force a 15 or 16-year-old to take their medicine. And so she did turn to the drugs and was self-medicating. And eventually she got into the heroin, and that was it. She couldn't get off. She tried many times. If you talk to somebody who's addicted to heroin and has tried to get help, normally they go into treatment sometimes 5, 6, 7, 8 times more, sometimes more. And she actually had been clean for 9 months when she overdosed. She was excuse me, part of the CREST program. And she had blood work done one morning, and it triggered her, she started getting cravings, and went out and used that evening, and I got a phone call the next day that she was dead.
And she wrote notes to you, or wrote messages to you?
And she had, we wrote letters back and forth. She spent 5 months in prison before she could get into the CREST. And I wrote to her every day, and she wrote back to me, and then came up with this brilliant idea to write a book, and this is what I want you to put in the book, and she would send me. So in the book, there's a lot of letters that she had written to me. I got a lot of this stuff from some of her journals.
But she wanted she wanted the book to help others.
Yes.
But did she think it would help her too? I mean, she wasn't.
That I'm not sure.
Yeah.
I know that she did tell me while she was in prison that when she got clean and she had enough clean time, she wanted to go into the schools and talk to the young people about her drug use and how it affected her life. And that's how I got involved with the Heroin Alert program. And I do try to go into the schools, although I find a lot of resistance from the schools to have me come in, and that I don't understand, but we're going to try to go over that hurdle soon.
Okay. I would imagine, again, the schools are very touchy about what our young people can be exposed to, I guess, and I would imagine
there's a lot of denial. I do. I still think, and I think it's a difficult subject anyway. And, for far too long, we characterized any behavioral health issues as character flaws, not really looking at this as a disease. And, and so we term this the disease of addiction. And indeed, when you think about Marie's life and the impact on her daughter, here we see a young person who also was living with bipolar disease, and sometimes self-medication early on is actually comforting for the individual. We've heard young people, and I know James can probably give you case after case, but we've heard of young people who actually might be experiencing anxiety, and when they take the prescription that maybe was their grandfather's prescription, they actually feel better about themselves and feel that they can actually socialize with their peers. So that provides a false sense of some type of a security that can then lead to a dependence, which leads to an addiction.
Exactly. I remember Erin, and I saw Marie's presentation, and having been around addictions, for a couple decades, it brought tears to my eyes. It gave me chills. And sort of like the fear is gone in some cases where individuals may understand that addiction is painful, but somehow life on life's terms, just being able to cope with life is challenging for folks, you know? And so there lies sort of like a dilemma with our folks that, you know, we have to do better in terms of understanding addictions and providing them with the resources they need.
And recovery is possible.
Oh, yes.
People living in recovery is very, you know, possible. And people live successfully, but again, you know, we just learned from another life lost in Robin Williams, you know, 63 years old, who, you know, was such a gift to all of us.
And we say to each other, who knew?
Right.
See, that's the part. Who knew? And again, but you're right. We focus on those who are not able to get over the addiction and something happens to them, as opposed to those who are able to cope with the addiction. You see it. Let me turn to the sergeant for a moment. You're on the front line, and we used Erin. We talked about Erin just a little bit in her life and her struggles. But I mean, what type of person is out there using heroin?
I mean, by the time I see them in the city, they've probably started out, this is generally speaking, on some type of opiate or painkiller addiction. It can be any type of person, any class of person. It can be from a simple car accident where they were prescribed some medication and they got addicted to medication. They weren't able to get that type of drug anymore, so they turned to heroin. It can be a worker who falls off a ladder and has a back injury. I mean, I can tell you probably thousands of stories. Every day, normal people get addicted, and I see them when addiction is them, when it consumes them. They'll do anything for the drug. You know, they'll trade their kids' diapers or formula for heroin. They'll prostitute themselves for heroin.
And this is why, you know, for those of us who think in terms of obeying the law, and why not to do something because you might get in trouble with a police officer, you know, it's like all that stuff, all those cautions that you have that you grow up with are all out the window.
It is in my experience, such a strong addiction that the fear of getting sick for them is worse than the fear of getting arrested by us.
And we have to do a better job at early intervention before people, you know, back in the 90s is when pain became one of the vital signs in our country. And if you look in the United States, we prescribe more painkillers than any other country in this world. Right. So, you know, a lot of what we do with the pharmaceuticals is you can take a pill for that, and that will help you with your pain, as opposed to how can we do pain management in a way, and sometimes pharmaceuticals are indeed very necessary, but how do we do it in a way that doesn't cause another issue for that human, and that, you know, could go into addiction. So what we saw here in Delaware is, you know, when we did start really doing that control relative to oxycodone and Percocet and Percodan, you know, we felt very good that here we're controlling these pain medications. And then the unintended consequence was, of course, what we're faced with now relative to the heroin market. So we are working with our physician community. They play a critical part in this relative to how do we do things in the area of pain management. We have to work with our medical schools. You know, Delaware uses Jefferson Medical School. We have to work at that level, so when we think about people who legitimately are experiencing pain, how do we deal with that in a therapeutic way that doesn't overly prescribe? And then some of the doctors have to become more aware of when they see somebody before them who may be experiencing substance abuse that can lead into a more permanent, you know, battle with addiction.
You know, anyone who watches any of the 3 networks, I know there are viewing habits for news and has changed drastically over the last few years. But if you look at any of the network newscasts, just about every commercial is some sort of pharmaceutical, some sort of drug. And you have to ask yourself, I mean, there are folks out there who are having issues. They have issues. They're trying to deal with things in their lives. and then they see this, and it's presented in such a way that it will help you. It will help you. It will make you feel better. And then I think the secretary, when you just mentioned the doctors, then you have to make sure that that network out there is working properly, and that some doctor is not just off doing something that maybe they shouldn't do. But all right, look, well, I'll tell you what. Let's take a short break, okay? We'll regroup. We'll come back in just a moment, and we'll continue our discussion on heroin addiction. It's addictions of all sorts that affect people here in Delaware and throughout the nation. But we'll be right back. Thanks for being with us. We continue with issues, and today our topic is heroin addiction, what's happening here in Wilmington, in Delaware, and throughout the nation, really. Sergeant, just for a moment, let me turn back to you I want to go back to the streets for a moment, and you talked earlier in the program about the batches of heroin available, and it's cheap, easily obtained by folks. What is the deal with the stamping of heroin?
Stamp is like a marketing tool, if you will, for drug dealers. It can denote a section of the city where they sell their drugs. Addicts can want a certain stamp if they get a particular type of high that they like.
And let me interrupt you. What we're talking about is if you look at a bag of heroin, there's a actual, there's some sort of a symbol or some sort of a stamp. Okay.
Correct. Heroin is usually packaged in what we call a blue glassine bag with some sort of plastic covering. And there can be different color stamps, red stamps, blue stamps, black stamps. Some of the recent names are Facebook or Google or Death Wish 2 or a type of vehicle, any kind of popular movie that's out.
I don't understand. I mean, I might understand Facebook if somebody, well, this is cool. It's, Facebook related. But why death? What? Death?
Well, the dealers have no real rationale around why they stamp it and what they stamp. It's just as the sergeant alluded to, it's an identifier, and it might have a ring to it if it's, like catchy.
And it can also denote where it's coming from. Philadelphia is one of our source cities for heroin. It can denote an area in Philadelphia where the drugs come from, or Baltimore.
My daughter used to get Philly, and she used to get Power Ranger. That was like
so
a cartoon.
She would look for that particular brand?
She knew right where to go.
That's amazing. To me, it seems stupid that there's for the bad guys, there's a way to track something on the one hand. But
they change it frequently as well.
Do they? Oh, it's incredible.
And they'll different dealers will be given an amount from, say, a source dealer in Philadelphia. Try this and see if your clients, if you will, like this.
All right, so let's turn to what we can do about all this for just a moment. The Secretary mentioned in the first segment of the program, it's almost like I'm hearing some things like when we talk about education. I'm hearing on education, I hear early intervention. I'm hearing the same thing when it's trying to wrap your arms around this of what an individual is struggling with. How do we get to folks early?
Well, and the sergeant's absolutely right. The sergeant's going to see people impacted sometimes before I do, unless you have people who recognize and are willing to come into treatment or ready to come into treatment. We know that the average age for those who are first entering our public treatment system is 33 years old. Okay. So if you think of Marie's daughter, she was still quite young. And we also know, along with this disease, that the probability of relapse is very, very high. But how we treated this disease for so long is when people would relapse, we would almost punish them for relapsing because they weren't compliant with their treatment plan. No other disease treats people this way. When I think of individuals with cancer, we don't punish people whose cancer, might go into remission and then come back. We don't punish that patient for that occurring, but we do so when we think of people who are impacted by addiction. So we have to kind of reset even how we think about addiction, and then we have to look at our challenge right now in the state of Delaware, like other states across the country, is indeed the capacity issue.
Okay, so that's what I wanted to get to. First, we assume that those addicted are actually reaching out for help.
Yes.
Well, that's the first hurdle,
right,
because some folks are not even at that point yet.
I think a lot of times when we arrest them, especially the first couple of times they're arrested, they're put into a treatment type program. You may know better. That'll be part of their diversion. That'll be put in part of their criminal. They'll wrap that criminal case up, and part of their sentencing will be treatment.
Okay.
And we can see an individual several times sentenced to diversion, fall off diversion, and go back.
Now, how much are we out of whack in terms of the demand and the capacity to offer treatment here in Delaware?
It's pretty intense right now.
Yeah, again, you talk about demand, so, we see record numbers of people trying to access treatment, but there's only limited numbers of slots. Now, we're doing the best we can in terms of opening up access, and the Secretary can share with you that. But I think, John, going back to early intervention and being able to do some stuff way before folks are of the age where they need to enter treatment. We have an adolescent program at Brandywine Counseling where we're targeting younger folks that are looking at experimenting with opiates. And so that's one area that we need to focus on. But then street outreach, getting the message out there that there is a dangerous drug out there, heroin that's poor quality, that's killing people. On the street level, our outreach workers have been able to communicate that with individuals. But then getting those folks, walking them into the treatment process, sometimes can be challenging. So that's where an intervention specialist come into hand. Many parents call us and says, I don't know what to do. Kids in denial.
All the time as well.
Yeah, kids are in denial. My son and daughters, they've been using this drug and now they need some help. What do they do? Yeah. So we walk them through that process, and the state has a significant number of providers, but again, demand has outweighed that.
But normally, don't they have to go into detox before they can get any kind of treatment?
Not in all cases.
Always. Yeah. Not always?
Yeah, but that does bring up the fact that we only have one detox in the state of Delaware.
There's only, 13 beds?
There's 30, but the public program only provides so much capacity. So we're looking at a redesign of our entire substance use, we call it substance usage disorder programs, and we know that we have certain gaps already existing in our system, detox being one. We need more capacity there, but we also need more capacity through the continuum of care, if you will. Even in the private sector, one of my concerns has been that even insurers, some people will tell me the public insurance Medicaid actually provides for more care than a private insurer would. So we need to start talking about parity. Again, this is a disease. Yeah. In chronic diseases that are, from a primary nature of health, the insurers pay for support in that area. In behavioral health, there really is a parity issue. So we're looking at, actually in 2015, January of 2015, all insurers are to treat behavioral health similar to the way that they treat primary care diseases.
I see, okay.
However, here's a little loophole. There's the definition of medical necessity that comes into play. So they get to define what they would consider medical necessity. Okay. So in Delaware, we're trying to pull those insurers around the table and start having these discussions. What does that look like? We know if we offer care and support and treatment, if we take into consideration relapse, that is less costly than if we actually evict people away from treatment and they go back to using.
What are the higher numbers as far as people seeking treatment? What does that say? Does that say that there's a greater realization that this is a problem and I need to help? And if so, then I guess we have to do something at some point to increase the number available slots.
We do. And the public treatment admissions for heroin are up by 118% since 2011.
Okay.
So you see, and that's heroin specific,
Yeah.
you can see just by the demographic the tremendous increase.
Now, why though, James? Is that, are people realizing I need help,
Well,
or why more people using?
Again, we mentioned it early on, but the prescription drug monitoring.
Okay.
So I no longer can go doctor shopping. Before you could go to your foot doctor, get a prescription, then your back doctor, get a prescription same month, and then your asthma doctor, get a prescription. Now you have 90 days supply of
I'm well medicated now.
right. So once we cut,
sell those drugs as well.
Yeah.
They sell those drugs or trade them for heroin too. So that's like a gold mine if they can get a prescription.
So we've gotten a
those
handle
drugs.
on overprescribing
Yeah.
now, and so you can no longer, run to your foot doctor, your back doctor, your asthma doctor to get that medication.
Which brings us back to the streets and to the bags and
Exactly,
so on and so forth.
exactly.
All right, now take me to, let's say we have someone who's now ready for some treatment. And now we get into the whole area of what treatment is available. And so what treatment is available today?
Well, there is a medication-assisted treatment for opioid dependency available. We use several drugs. The most popular that you hear about is methadone.
Methadone, that's
But we
what I
also
know.
use buprenorphine, Subutex, and Suboxone.
Are those three, and I'm sorry if I cut you off, is there another one?
Yeah, Vivitrol.
Okay.
Vivitrol.
So if you have four out there, basically, are they all like substitutes? Or are you just keeping someone addicted to something else, or?
And you hear a lot that there is a big debate, but the way I want you to think about this is like you would any disease. We know that for instance, for people with anxiety, sometimes they will require Xanax, if you will, to help them with that anxiety. Sometimes that anxiety is episodic. And many times people will have lifelong anxiety, and they may need a level of medication to assist them through their lifelong anxiety. I think what is critically important is that our treatment system must be very individualized and cannot be conducted in a vacuum. Everybody gets this type of approach. For some people, just like smoking, some people, abstinence, they can one day smoke, the next day not. That's a strong addiction as well.
Absolutely.
When we think about people addicted to alcohol or to opiates, it should have a very individualized treatment plan that's inclusive of doctor support as well
treating the whole person, both spiritually, emotionally, physically, and in many cases using medications.
And whatever it was that maybe drove them to that addiction to begin with that was out there. We don't have a magic pill.
Yeah.
Okay, so if we had the magic pill, it's like anything we talk about with addiction, that'd be wonderful. But in the meantime, I guess, are we doing what we can?
I think what we hear a lot on the street is they don't want to get sick, so they get their methadone just to try and keep them at a happy medium, if you will.
I see. Okay.
But eventually, and I don't really know.
Right. Well, everybody's not appropriate for methadone, and so that's why we have some other drugs we use. But I want to make this point about methadone. Methadone has been around since the late 60s, and it is the most researched and the most regulated medication for opioid dependency in the world. And so we have tons of research and literature and best practices. We've gotten better as providers in terms of how to treat individuals, using that individualized treatment approach, and also connecting them back with community, family, and individual counseling as well. These are all critical pieces in the recovery process.
All right, look, the time has gotten away from us, as it always does on these programs, so we're going to have to wrap it up. But look, there are a few messages here that are pretty clear. If you have a problem and you're struggling with some things internally, there are ways to reach out. In fact, you'll see some resource numbers and agencies listed on this program, and so we want you to take advantage of those. The other thing that we're hearing is, approach this at an early stage if at all possible. I advocate, I can advocate if I want to, that the book, Dope Help, maybe be added as part of a curriculum in the educational curriculum in terms of alerting young people to what they may be facing if they're not careful. So you've all been great, and I thank you so much. It's something that we continually struggle with. We're just going to have to continue. I don't care if somebody's in treatment, they could relapse, and then you're starting all over again. So, but thank you very much for your time on this issue, and we want you to seek help.
Thank you, Jim.
All right, thank you. If you have any thoughts on this discussion, please tweet them at WITN22 WILM, #issues22, or you can post your comments on this video's YouTube page. For WITN22 in the city of Wilmington, I'm John Rago. Thanks very much for being with us.